അജയ് മ്യൂട്ടാണ് തോന്നുന്നത്.
Ranjit.
Okay. So clear.
Good evening, sir.
Mohandas, sir.
Ajay, we can start.
Okay. Good evening, everyone. Today we are having again one more meeting, that is a Sat series, which is a general practitioners meeting which we have on all the Fridays. And this meeting is actually special because this time we are having the launch of Presidential Action Plan on Oral Health by none other than our President of IAP Kerala, Dr. T.P. Jayaraman. First of all, I would like to welcome Dr. T.P. Jayaraman, sir, for this meeting. And this is one of the programs which we are conducting along with Indian Dental Association Kerala branch, and as well as all the districts branch all over Kerala. And we have Dr. Mukesh Kea, Vice President of IAP Kerala and Chairperson of the Presidential Action Plan on Oral Health. We welcome you to the meeting, sir. And representing IDA Kerala, we have Dr. Joseph C.C., the President of IDA Kerala, and Dr. Deepu J. Matthew, Secretary of IDA Kerala. We thank you for all the supports you are giving to IAP Kerala, and I also welcome you to the meeting, sir. And we have Dr. Nandakumar, sir. Sir is a National EB member of Central IAP. We welcome you to the meeting, sir. And I also welcome Dr. Johnny Sebastian, the Dynamic Secretary of IAP Kerala, who is the support for all the activities of IAP Kozhikode. Welcome to the meeting, sir. And representing IDA Malabar branch, we have Dr. Shaju Mandoli. I welcome you to the meeting, sir. And also Dr. Ajit Subhash, sir. Sir is the convener of Presidential Action Plan on this oral health of IAP Kerala. We welcome you to the meeting, sir. And I also welcome all the dignitaries, IAP Kerala President-elect Dr. Vijay Kumar, sir, and all the senior faculties and the senior IAP and the IDA members, and all my colleagues to the meeting. So we directly will go to the presidential address and inauguration by Dr. T.P. Jayaraman, sir.
Good evening, everybody. Hope I'm audible.
Yes, sir.
Respected President of IAP Calicut, Dr. Mohandas, Secretary Dr. Ajay, President-elect of IAP Kerala, Dr. Vijay Kumar, Dr. Johnny Sebastian, Secretary, Dr. Mukesh, Vice President, Dr. C.C. Joseph, President of IDA Kerala, Dr. Deepu, Secretary of IDA Kerala, Dr. Kannan, the guest speaker of the day, Dr. Ajit Subhash, Dr. Nandakumar, Dr. Sudha Madam, and all the other delegates on the platform. Oral health in children is of much importance from the birth of the child. Teeth and supporting structures have an important role in aesthesis, in maintaining the speech, mastication, as well as this has an important role in boosting the self-confidence of the child. And there are a lot of problems affecting the oral health in children. And to maintain the teeth in good form, we have to be aware of the common problems affecting oral health in children. And in day-to-day practice, pediatric dental problems constitute a major chunk of our office practice, where we have to be aware of the problems and where we have to direct people to the appropriate person for the appropriate cure at the appropriate time. And this is a feeling which I have during my last 35 years of practice. I have felt that this is a much neglected area in pediatric office practice, and I feel many of the dental surgeons are also hesitant to handle pediatric problems. That is my experience in my practice. And I felt we have to be equipped with the current knowledge in oral health. And I thank Dr. Mukesh, Vice President of IAP Kerala, for suggesting this to be included in this year's action plan and agreeing to be the state coordinator of this program for the year. And I thank Dr. Kannan, Vice Principal of the Dental College, Calicut, for giving the academic content in preparation of the module, and also the President and Secretary of Indian Dental Association for willing to be associated with us in the rolling out of this program and to be a knowledge partner in this program. And I thank Dr. Mohandas and Dr. Ajay of IAP Calicut for giving us a platform to launch this important action plan of the year. And I wish the very best for the program and also to IAP Calicut and for today's CME. Thank you all for giving me this opportunity, and I declare that this action plan is inaugurated. Thank you all once again.
Thank you, sir, for the presidential address and launching of the IAP presidential plan on oral health. Now I invite Dr. Mukesh Kaya, our Vice President of IAP Kerala and Chairperson of the Presidential Action Plan on Oral Health, who is the main man behind the action plan on oral health.
Respected State President TPJ sir, and IAP Calicut President Dr. Mohandas, Chief Guest Dr. Kannan, and IDA State President and Secretary, and our Secretary Dr. Johnny, and dignitaries and my fellow IAPians. A warm good evening to one and all. Today we have planned for a very important CME, considering the action plan of our State President, a pet project of TPJ, Progress, of which the O representing the oral health. Oral health is inseparable to general health. It affects one's self-esteem and quality of life. Today, we have an eminent speaker to enlighten us on this topic. I am sure all the pediatricians will be benefited from this vital speech. I wish all the success for this program. Jai IAP, Jai Hind.
Thank you, sir. Now I invite Dr. Joseph CC, President of Indian Dental Association Kerala, for felicitations.
Respected Indian Association of Pediatrics Kerala State President Dr. T.P. Jaram sir, IAP Kozhikode District President Dr. Mohandas sir, Indian Dental Association Kerala State Secretary Dr. D. Pujay Matthew, our esteemed faculty Dr. Kannan sir, Dr. Mukesh, Dr. Nandakumar, Dr. Johnny Sebastian, IDA Malabar Branch President Dr. Shaju Mandoli, Dr. Ajit, dear IAP members, dear IDA members and friends. IDA Kerala State is really happy to associate with the Indian Association of Pediatrics in this webinar, Dental Problems in Childhood. Childhood is the most important milestone in a person's life period. And in this important period, dental pain and dental related issues spoils health and happiness. So, really happy to see Kannan sir as faculty in this relevant topic. Actually, the parents really want the very best for their children in their dental health. But it is essential to promote healthy oral hygiene habits. Tomorrow, World Oral Health Day, March 20th. So, it is very important to observe this day for this topic. Is really relevant. Another important aspect in dental treatment is in childhood is regarding dental treatments is anxiety and other phobias. Really, Kannan sir will deliberate all these issues. I wish this program a grand success, and IDA Kerala State is really happy, and we will associate in more cities like this in the near future. So, thank you, everyone. Wishing you all the success. Thank you.
Thank you, sir. Thank you for your wholehearted support. Now I invite Dr. Nandakumar MK, our National EB member of Central IAP, for felicitations.
Respected President Kerala State IAP, Jayaram sir, IAP Kozhikode Bank, Dr. Mohan Das, dignitaries on this platform. So as you all know, dental health is one of the most important aspects in pediatric care, but unfortunately it is one of the most neglected part in our day-to-day practice. So I really thank IAP Kerala led by our dynamic president Jairam sir for including this in 2021 action plan. I wish all the best for this program. Thank you. Thank you.
Thank you, sir. Now I invite Dr. Johnny Sebastian, our dynamic secretary of IAP Kerala, for felicitations.
Respected President, am I audible?
Yes, sir.
Yes.
Respected President Dr. Mohan Das Nayak, my leader and President IAP Kerala Jayaraman sir, Dr. Vijay Kumar sir, President-elect, Dr. Mukesh KR, Vice President and Chairperson of the Presidential Action Plan on Oral Health, Dr. Nanda Kumar, National Executive Board Member, CIAP, Dr. Joseph CC and Dr. Deepu J. Matthew, President and Secretary from IDA Kerala, Dr. Shaju, President IDA Malabar, and my dear friend Dr. Ajit Subhash, convener of the President Action Plan on Oral Health, seniors and my dear friends. At the outset, I would like to congratulate IAP Kozhikode for giving this platform to launch our Presidential Action Plan on Oral Health. And as usual, you all know they have come up with a very grand plan for the launch of this program today. Oral health, as Jayaraman sir has pointed out, is not given much attention in our office practice. So I feel this action plan is very important, and with the help of IDA Kerala branch, this would definitely help our children. I wish this program all success. Thank you. Jai Hind, Jai IAP.
Thank you, sir. Now I invite Dr. Deepu J. Matthew, Secretary of Indian Dental Association Kerala, for felicitations.
Thank you, Dr. Ajay. Evening to everyone. Chairman of the day, Dr. E.P. Jayaraman, IAP President. Respected Chairman of Calicut, President of Calicut of IAP, Dr. Mohan Das Nayak. Dr. Mukesh, the Chairperson on the Presidential Action Plan. My own President, Dr. Joseph CC. Dr. Nanda Kumar, the Secretary of IAPA, Dr. Johnny Sebastian, Dr. Shaju Mandoli, other dignitaries, and of course, the faculty of the day, Dr. Kannan. It is indeed an honor for the Indian Dental Association to be associated with the IAP in this project. This is a glaring example of the lack of awareness about oral health problems among the public and especially in the government sector. It is fitting indeed that on the eve of the World Oral Health Day that such a project is being rolled out, and we are in IDEA are indeed committed and we're ready at all times to join hands to make this program a grand success. I must also stress at one point this is going to help us in another manner, because all over in our land, in our nation of India, there is till date there has not been oral health policy, and we in the IDEA have been behind this, and now there is a draft of the oral health policy being issued at the national level, and during these times IDEA has recommended to the state government also and to the various political fronts who are coming up for the election that we need a definite oral health policy in the state of Kerala. This has been a demand of ours to all the political friends, and it's such an association with IAPA will definitely help us to realize that goal. And I request all of you esteemed members, esteemed senior doctors in our state to please, whenever someone requests you to please voice our concerns also too about the lack of an oral health policy and the lack of awareness. And like all the senior members were saying, it is indeed noteworthy, and we thank you all for considering our association in taking up your project, and I assure you that we will do our level best for your project. Thank you all, and thank you very much.
Thank you, sir. Thank you for your wonderful comments. And now I invite Dr. Shaju Mandoli, President of IDA Malabar, for felicitations.
Respected leaders of IAP, my dear members of IDA, first of all, let me congratulate the leaders of IAP for choosing dentistry as the main project, of yours in this year. And I'm very happy to see that one of our senior member and a very good friend of mine, Dr. Kannan sir, as the speaker of this program. We, the Idea Malabar, is always ready to take part in any of the projects of IAP this year. For any need, please contact us. We are ready to help you at any time. Thank you, sir. Thank you very much.
Thank you, sir. Thank you for your comments. So right now, I think we'll go for the academic sessions. We have Dr. Kannan. He's a professor and HOD of Periodontics of Government Dental College, Calicut. I invite our esteemed IAP Kerala President-elect, Dr. Vijay Kumar sir, who is the moderator of the session, for introducing our speaker, Dr. Kannan.
Good evening, everybody. It is my pleasant duty to introduce my best friend, Dr. Kannan. Dr. Kannan is now Professor and Head of the Department of Periodontics, Government Dental College, Calicut, and Vice Principal, Government Dental College. And actually, we started our career in medical profession together. And he is having a vast experience. He did his BDS in Government Medical College, Kozhikode, and MDS from Trivandrum. And he's a teaching faculty for the last 26 years. And he has a vast experience in pediatric dental problems. I'm not continuing it. He is having more than 30 publications in index journals. So for our Presidential Action Plan progress, we have included dental health as a major program. And this is the inaugural day of our Presidential Action Plan. And I invite Dr. Kannan to present his topic on pediatric dental diseases. Over to Dr. Kannan. Thank you so much for accepting our invitation, sir. Over to you, sir.
Thank you, Dr. Vijay Kumar, for your nice words. And I would like to thank all the organizers of this program for inviting me for this continuing medical education program. And I sincerely congratulate the IAP for selecting oral health or dental health programs for this year, 21-22, I think. Slide. Shall I straight away go to the topic?
Yes.
Yes, sir.
Yes.
We'll make
Okay.
slideshow.
We are trying to slideshow from our side itself. If
Yes, sir.
needed, please help us. Okay.
It's correct, sir.
Okay. Since the topic is regarding the oral health of children, we have to mention about the structure of a tooth. First, we have to mention about the structure of the tooth. Because some people doesn't know how many layers are there in a tooth. The outer cover, that is what we have seen, is a white portion. That is known as the enamel. The second portion, that is just beneath the enamel, that is dentin. And another portion, that is pulp, that is inside the dentin. Pulp includes the blood vessels and the nerve tissues and fibers and all. The vital portion of a tooth is pulp. And the other two portions covering this pulp, actually.
Slide is not seen.
Yes, I am just an introduction like that. Is
Okay.
I will change the slide later. He said. Okay. And the enamel portion I mentioned about, that is the outer covering. In deciduous tooth, there are in human dentition, there are 3 types of dentition. One is primary dentition, that is otherwise known as deciduous dentition. Primary tooth is that will shed and another tooth, successor tooth, will erupt in the same place. Second dentition is mixed dentition. Mixed dentition means, I mean, I have to mention about the time period. Primary dentition actually start from 6 months of a life of a child. That is 6 months. That is almost 6 months, a little bit late, or sometimes it may be earlier. Normally it is 6 months. Starting of eruption of tooth, primary tooth. The first tooth which will erupt in the lower anterior region. Anterior region means front portion, in the lower segment. And later on, lateral incisor, canine, molars, like that. Primary dentition contains 10 teeth in the upper arch and 10 in the lower arch. Total 20 teeth. Then come to mixed dentition. Mixed dentition actually start from 6 years to 12 years. Because I already mentioned that by 6 months, deciduous dentition or primary dentition will start, and almost by 2.5 years, all the deciduous or primary teeth will be erupted. That means the second molar will erupt in the oral cavity. One central incisor, one lateral incisor, one canine, one first molar, and one second molar. In each quadrant. Quadrant means in the lower region, in the mandible, it will be in both sides, 5 each, and the same thing in the upper arch, 5 each. Total 20. And in mixed dentition, what will happen is permanent tooth also will be starting to erupt in the oral cavity. The first permanent tooth is erupting by 6 years. 6 years, 2 teeth will erupt simultaneously. One is central incisor in the lower arch. That means one central incisor in the lower arch will shed, and a permanent central incisor will erupt in that place. That is the starting of mixed dentition. During that time, by the 6 years itself, a permanent first molar will erupt just back to primary second molar. During that time, one permanent first molar in each quadrant. Each quadrant means lower left, lower right, upper left, and upper right. 4 first permanent molars will be there in the oral cavity. At the same time, lower central incisor, right and left, will be erupted. That is the starting of the mixed dentition. Okay. Why it is called mixed dentition is permanent teeth and deciduous teeth are in the oral cavity. Till 6 years, only primary teeth will be in the cavity. The main difference in the permanent and the deciduous tooth in structurally, the thickness of enamel and the dentin will be very thin in deciduous tooth, and the pulp portion will be comparatively larger. At the same time, permanent dentition, enamel dentin will be very thick, and the pulp portion will be comparatively less. That means the covering for the pulp will be more thicker. That is an important portion. And the third type of dentition, that is permanent dentition. In permanent dentition, only permanent teeth will be there. That means all the primary teeth will be shed off That will happen by 12th year. By 12th year, all the deciduous dentition will be shut off. Only permanent tooth will be there. By 12, one major difference in primary and permanent dentition is that in deciduous dentition, there will be no premolars. Only incisor, central incisor, lateral incisor, canine, and 2 molars. But instead of that, instead of 2 primary molars, there will be 2 premolars. First premolar and the second premolar will be there. And the first molar will be behind that. That means behind the or back to premolars. And during the time of 12 years, all the primary teeth shed and permanent teeth only will be in the oral cavity. Okay. Then after 12 years, almost 13 years, second permanent molar will erupt behind first permanent molar. And by the age of 18 years, it's not a correct age because from 18 onwards, there will be third molar. Usually it is known as wisdom tooth. By 18th year, there will be an, eighth tooth. From counting from central incisor, that will be the 8th tooth, that is third molar. Okay. But there is some difference in between that in permanent dentition, full permanent dentition by 18th year, that may extend up to 30 or 40. Sometimes permanent final molar or wisdom tooth will erupt by 35 years. Sometimes that may happen, but usually for me it was in 18 years. During that time, in our oral cavity, there will be 32 teeth. 32 in permanent, but in deciduous dentition only 20. Then there is a difference, that is 12 teeth. They are additional. First permanent molar, second permanent molar, and the third permanent molar in each quadrant. That means in 4 pieces, 3 each, that is 12. These teeth which I mentioned, that is first, second, and third molars will erupt only once in a human life. Only once. But the main thing I have to mention is that during mixed dentition period, permanent first molar will erupt by 6 years. There is a misconcept that all the teeth will shed up to 12 years. That is a mistake, because by 6 years, permanent first molar is already erupted, but that will erupt only once. That is a permanent tooth. But just in front of this permanent first molar, deciduous molars are there. That molars will shed, and in that place, premolars will erupt. Canine will shed and a new permanent canine will erupt. But this first, second, and third permanent molars in each quadrant, that is 4 places, total 12 teeth will not erupt in second generation, only one. The relevance of this first permanent molar is that first permanent molar is erupting in the oral cavity in the mixed dentition period. So never think that up to 12 years, only deciduous teeth will shed. This first permanent molar will not shed, and that is a permanent setup. Unfortunately, many times, if there is a caries lesion in the permanent first molar, people will think that it will shed. Never. And one more important point is that if this first permanent molar is very important for our this integration of the arch, and at the same time mastication, mainly it is used for mastication. Mastication means chewing. So be very careful. If you see a patient, you have to See, if it is that patient is above 6 years, the last tooth erupted in the oral cavity, that is a permanent first molar, and never neglect permanent first molar. Okay. I am repeating the same thing. Primary dentition, that is known as deciduous dentition. You can see only primary teeth in the oral cavity, that is central incisor, lateral incisor, canine, first molar and second molar. This is also known as milk tooth. And mandibular central incisor is the first tooth erupting. Mixed dentition I mentioned. You can see two four upper incisors. That is two centrals and two lateral incisors in the upper arch, and two central and two lateral in the lower arch are permanent tooth. At the same time, as permanent first molar is already erupted in the behind the second primary molar. This is known as mixed dentition. Both the deciduous and the permanent teeth are in the oral cavity. Okay. Here it is a picture of permanent dentition. There is no deciduous tooth, fully permanent tooth. Usually it happens by after 12 years. 12 years only. Before that only permanent incisors, canines, premolars, but not premolars, primary molars will be there just before 12th year. By 12th year, all the deciduous teeth will be shed and permanent tooth. I already mentioned about the presence of premolars. In the place of deciduous molars, there will be two premolars. First and second premolars will be there. Total 32 teeth in the permanent dentition. This is after 18 years, I have to mention. Okay, from 12 years, it is permanent dentition only. Sorry. Here it is. You can see a special tooth seen in between central incisors. A conical shaped tooth in between central incisor. It is known as mesiodens or supernumerary tooth. I have to mention that some abnormalities in number and size and shape of teeth usually occur. Usually I mentioned about 32 and 20, deciduous 20, permanent 32. But sometimes there will be an increased number of teeth in the oral cavity. That is known as supernumerary. We can mention about the supernumerary post in certain government offices. Just like that. Apart from the normal, there will be an increased or additional tooth that is known as supernumerary. Only thing we have to do, remove it. Otherwise, that will create some problem. The main importance of this tooth, that may create some problem for the permanent tooth. It may create, it will create a space in between central incisor, and there will be some crowding. Rarely in the lower anterior region also supernumerary tooth may erupt. That conical shape is mainly we can identify this teeth. Another issue is that reduced number of teeth in the oral cavity. That is, a number of teeth will be less. That may be due to congenital missing of certain teeth. Usually, permanent lateral incisors may miss the tooth, but may not be there in the oral cavity. It may not erupt. During that time, we have to give rehabilitation like partial denture or something like that. That is a reduced number. At the same time, another thing I have to mention is natal and neonatal tooth. Natal tooth means the tooth which is erupted in the oral cavity at the time of birth. Immediately after birth, we can see a white tooth-like structure in the oral cavity. Usually, it will be seen in the lower arch. See this picture. There is a white structure seen in the lower anterior region. That is natal tooth. While at the same time, if such a structure is seen within 1 month after birth of the child, that means within first 1 month, that is neonatal tooth. These are actually deciduous tooth, but erupted earlier due to so many reasons. I'm not going to explain all these things, but you should understand that it is a deciduous tooth which is erupted earlier. The main problem with this natal and neonatal tooth is it may create some issues in the tongue. That is Riga-Fede syndrome. You can see it may create ulceration. At the same time, while feeding, the mother also will suffer because it may be little bit mobile and it will be sharp also. And that may create ulceration in the nipple and create some swelling or infection or something like that. So if it is mobile, it is better to remove that tooth because it may create ulceration, infection. Sometimes if it is that much mobile, it may be aspirated. That's also a serious issue. That aspiration may lead to aspiration pneumonia or something like that. So if it is creating any issue, better to remove. Sometimes it may not be creating any issues, let it be there. That's all. When permanent tooth is erupting, we can manage, no issue. Then we are going to the common dental problems in children. As you know, the main problem with pediatric dentistry is caries. Caries means in Malayalam it is curd, some area it is known as pod. It is some decay of the tooth. The first one is decay. Why a tooth become decayed? That is a question. Usually, as we see the advertisement of certain toothpaste, we can see some creatures, that is representatives of bacteria. They are hitting the tooth with a certain sharp instruments and creating some problems for the tooth. Actually, that is not correct. Bacteria in the oral cavity, lakhs and lakhs of bacteria are in the oral cavity. These bacteria will react with the foodstuff which is in the oral cavity, foodstuff, milk or anything. That will actually, bacteria is doing a fermentation process in the oral cavity when it is not disturbed. If it is available for the bacteria, they will do fermentation for their own purpose, for their eating purpose. As a byproduct, an acid will be produced in the oral cavity. As you know, the pH of the oral cavity is a little bit alkaline, pH, acidic level in the oral cavity. And if the bacteria is producing acids as a byproduct, what will happen is the pH of the oral cavity will be reduced. And it will reduce and reduce. And if the acid production is more, the pH will come below 5.5. That is acidic. And if it is 5.5 for a long time, what will happen is it will create problems or erosion on the tooth surface, which is, that means mainly in the enamel, especially in the occlusal region of the tooth, especially primarily in the molar. And I will come to the next portion later. In the molar, you can see the first picture, that is a carious tooth. caries means decayed tooth. When the pH is reduced below 5.5, it will happen. I mentioned that if the bacteria and the substrate, that means the fermentable carbohydrates in the oral cavity, is stayed there for a longer time, then only this acid production and this pH reduction, everything will happen. That is why we are telling you that the fermentable carbohydrates in the oral cavity should be removed frequently. That is, brushing of the teeth at least 2 times, and if possible, after every meal. It is better to remove the fermentable carbohydrate from the oral cavity. If it is brushed and removed, the bacteria can't do anything. I have to mention about the nursing caries. Dental caries, I already mentioned, dental decay processes. Here it is bacteria or germs, food and drink, sugar, sweets. Then the product will be acid that will act on the healthy tooth and the cavity will be there. And I mentioned about the caries. Then another problem is missing tooth. Missing tooth may be due to absence of the tooth. That is first. Sometimes there will be no this tooth bud inside the arch. And another thing is extraction or removal due to the caries process. I will come to that point again. Another portion is periodontal problems, that is, which will affect on the gums of the patient. Another issue is tooth fracture. Fracture may be due to trauma, that is a fall or any hit in a hard object, and sometimes accidents like that. I mentioned about the process of cavity. Then you can see the tooth anatomy, which is the outer white portion is enamel, then yellow portion is dentin, and that you can see some innervation pulp and nerves, that is pulp, and the main portion is root, which is seen in the alveolar bone, and the gum will be cover up this region. Usually root and crown, there are two portions. Root is inside the bone and crown is outside the bone. The crown is what we are usually we can see, but the root is will be inside the alveolar bone. The stages of the caries development I mentioned about it. First, when the pH is reduced, what will happen is it will create some erosion on the enamel surface. Usually what happens, it is known as actually demineralization. The mineral portion of the enamel is eroded, or some dissolution of the this portion, that is enamel dissolution, is happening due to this attack of the acid. That is demineralization. At the same time, another word is remineralization. Demineralization and remineralization. There is a cycle like that. If the acidic content in the oral cavity is increased, then demineralization will occur. After that, the minerals from the oral cavity, from food and from the saliva, there are so many minerals are there. Calcium, phosphates, fluorides, like that. They will remineralize. Then demineralization and remineralization will happen, and the tooth will be intact, actually. But whenever the remineralization is less and the demineralization is more, the result will be a cavity. For encouraging or enhancing the remineralization, we are using toothpastes and some other remineralizing agents. By use of this, demineralized tooth will be remineralized. But if it is not balanced, there will be cavity. First, it will affect the enamel, then it will go to dentin. During enamel portion, if enamel portion only is affected, there will be no pain, no issue for the patient. And if it is dentin is affected, there will be no that much of pain. But sometimes if you eat sweets or cold or hot foods, then only there will be some problems. And if it is very deep and when it is reached into the pulpal region, nerves will be stimulated and there will be pain. After that, definitely there will be formation of the abscess or cellulitis will be the severe pain. We will call it as a pulpitis in the third stage. That means whenever it affects the pulp, there will be pain. That is known as pulpitis. Caries are different types. I mentioned about the occlusal surface means the area which is used for the chewing. That is occlusal caries. Enamel caries, that will be, you can see a small caries on the occlusal surface, that is enamel caries. Pit and fissure caries means this occlusal area will be having so many pits and fissures. It will not be a smooth one. There will be some irregularities. That irregular region will be affected by caries because we stay there and the food stuff can be enlarged in that region. If it is a smooth area, it cannot happen. So this occlusal surface is always affected by the caries lesion. To prevent this type of caries, we can use pit and fissure sealant because that is a composite type of material. We can fill that area. You can see that third picture. There is a white material is used for sealing that area. Then this food enlargement and bacterial invasion can be prevented. And regarding dental caries, you can see in the lower portion of the slides, there are deep caries and that caries is removed with our instruments and later it is filled. The lower portion is a filled tooth, that is composite material or glass ionomer cement can be used for filling it. There is a concept in earlier times that if a tooth is decayed, just remove the tooth. That was a concept earlier. But we are trying to not remove the tooth. The tooth should be there in the oral cavity. Why the tooth should be in the oral cavity for a long time? The tooth should be there for our mastication. Mastication means chewing. If the tooth is there, the chewing will be effective. If the food is chewed properly, then only the digestion of the food material will be properly happen. Otherwise, it may create GIT problems. And another thing, the phonation for speech, tooth should be there. Otherwise, we cannot speak properly. The escape of the air will be there. So it is very difficult to speak properly, especially for those who are singing. It is very difficult. And another thing, if the tooth is lost untimely, the growth and development of the arch, that is mandible and maxilla, will be affected. If the tooth is there, that integrity of the arch will be there. Otherwise, it will shrink and the shape of the face will be a different one. Here, this slide shows the deep caries in a molar tooth. And in such a cases, we can use temporary filling. And if there is no pain after 6 weeks, we can consider permanent filling. But if an early caries, we can do permanent filling directly. And the tooth is, suppose that the tooth is affected very seriously and the pulp is involved and the severe pain is there, we can consider root canal treatment, pulpectomy. Pulpectomy means removal of the affected pulp and filling of that region with some medicaments. Medicaments in deciduous tooth, we are using calcium hydroxide or zinc oxidiogenol or so many ready-made materials are there. In permanent tooth, it is gutta percha, another thing, because deciduous tooth, we have to use materials which will resorb when the permanent tooth is erected. All the deciduous tooth will shed when the permanent tooth is coming from inside, and the resorption of the root will be there. That is a reason for mobility and shedding of deciduous tooth. So we are using a resorbable material in the root canal of deciduous tooth, whereas in permanent, non-resorbable materials are used. In the last slide, we can see there is a metal portion, that is stainless steel crown. In deciduous molars, especially after the root canal treatment, we are using a stainless steel crown. That is a ready-made thing. We can put on it after some modification. Otherwise, this endodontically treated or root canal treated tooth will become brittle. So we will not get much advantage of the root canal treatment. So it's better to use a stainless steel crown. There are tooth colored crowns also available. That will be a little bit costly. Then I mentioned about the caries. Caries means the decay of the tooth. You can see two pictures. This is the situation. We call it as early childhood caries. Early childhood means it is in very early age of a child. There will be multiple caries in the oral cavity. Especially you can see in the anterior region. Anterior region means front region. Some terminologies are different. The posteriors means the molars and back tooth, and the anteriors are front tooth. You can see many caries are there. Nursing caries, I have to mention about nursing caries. Nursing caries is mainly occurring due to nursing, that is improper feeding techniques. One is use of nursing bottles. Usually, you know, the cow milk is filled in the bottle and sugar is added and it is given to the child for a longer time. They will drink it whenever they want. During sleep also they are drinking the same thing. When they sleep, the nursing bottle will be there in the oral cavity. What will happen is, when they sleep, the bottle will be inside their mouth and a full mouth of sugared milk will be in the oral cavity during that time. What will happen? I mentioned about the process of fermenting, production of acid, erosion of the enamel, like that. The same thing happen in the oral cavity. Mainly it will occur first in the upper anterior region, then only in the posterior region. Lower anterior region will not be affected because the tongue will be placed on the lower anterior teeth. That means lower incisors will be protected due to placement of the tongue over that. When the nipple is placed in the oral cavity, tongue will be just above the deciduous lower anteriors. So that region will be protected, but all the other teeth will be affected. You can see the color of the tooth. In the second slide also, it is pathetic, you know. See, the child is sleeping with the bottles Then second one is also, and the third one is sometimes pacifiers coated with honey or artificial sweetness. And many times mothers will sleep with the child when the child is breastfeeding. I mean, the child is breastfed and the mother will be sleeping during that time. What will happen? In between, the child will be sleeping and one full mouth of breast milk will be inside the mouth. And that also creates so many issues. Mainly this caries formation. Second one is many times there will be
not very clear. Dr. Kannan, not audible.
Karan sir?
It's a connection problem, I think. It's not moving, no sound.
Kanan sir, can you hear? Vijaykumar sir, no, can you just call?
സാറ് വിളിക്കുന്നുണ്ടല്ലോ, ജയ വിളിക്കുന്നുണ്ടല്ലോ.
Kanan sir?
അജയ് എത്ര പേരെ കേട്ടായിരുന്നു?
Sir, on the slide.
ഞങ്ങള് വീണ്ടും കയറി. എനിക്ക് പിന്നെ അജയനെ കാണാൻ പറ്റുണ്ടല്ലോ.
ഇപ്പൊ കേൾക്കാം സാർ. സാർ ജസ്റ്റ് ഒന്ന് ഷെയർ സ്ക്രീൻ കൊടുത്തേ.
അജയ്
ഇപ്പൊ കേൾക്കാം.
എവിടെ വരെ കേട്ടു? എവിടുന്നാ കേൾക്കാതായേ? സ്ക്രീൻ ഷെയറിംഗ്. അജയ് ഇപ്പൊ കേൾക്കാമോ? കേൾക്കാമോ? നൈറ്റ് ഫീഡിംഗ് വരെ കേട്ടോ? ബോട്ടിൽ ഫീഡിങ്ങിന്റെ കാര്യമൊക്കെ പറഞ്ഞതൊക്കെ കേട്ടു. അതിന് ശേഷമാണ് കേൾക്കാത്തത് അല്ലേ? ഇപ്പൊ ക്ലിയർ അല്ലേ?
ഷെയർ ചെയ്താ മതി സാർ.
ഒന്ന് ഷെയർ ചെയ്യും. ഇപ്പൊ കുഴപ്പമില്ലല്ലോ, ഓഡിബിൾ ആണല്ലോ. ക്ലിയർ ആണ്. ഇനി ഷെയർ ചെയ്യും.
ഹോസ്റ്റ് ഷെയർ ചെയ്യാൻ പറ്റുമോ? ഒന്ന് ഹോസ്റ്റ് ആക്കാൻ പറ്റുമോ?
ആ ഹോസ്റ്റ് ആക്കാൻ പറ്റും. ഹോസ്റ്റ്
ഹോസ്റ്റ് ആക്കാൻ പറ്റും.
ഹോസ്റ്റ്
ആ
ആകാം ആകാം ആകാം.
ഓക്കെ ഓക്കെ ഓക്കെ. ബിജുകുമാർ ചെയ്യാം.
co-host ആക്കി.
ഇനി ചെയ്യാൻ പറ്റും നോക്കൂ.
ചെയ്യാം.
ഇനി ചെയ്യാൻ നോക്കാം.
കണ്ണൻ ആ പാസിഫയർ ഇല്ലേ?
ആ ഞാനിപ്പോ ചെയ്യുന്നുണ്ടേ. ഒരു
പാസിഫയറിന്റെ മുതൽ
ആ ഹണിയുടെ കാര്യമൊക്കെ പറഞ്ഞു.
ഹണിയിൽ എങ്ങനെ നിൽക്കുന്നത്?
അത് ശരി, ഒന്ന് ബാക്കിലേക്ക് ആക്കി. അത് പലപ്പോഴും എന്താ വെച്ചാൽ പാസിഫയർ ഹണിയൊക്കെ കുട്ടികൾക്ക് ചില സമയത്ത് കൊടുക്കും. Okay, shall I move to the next slide?
Yes.
Complications of caries in children that I want to mention about it. The main thing, you can see the anesthetic appearance. It is understood that there will be an anesthetic. Usually when these children are going to school or nursery school, the peer group will always laugh at them. They will put some nicknames for them, like Pulupallan or something. Some bad comments will be there. So that will affect the mental status of the child, because sometimes if it is continuing, they will be hesitated to go to school or participating in school programs like that. And sometimes they may be turned to introverted in certain cases. This appearance will be like that. If they see their a picture like this in a mirror, they will be desperate. That is one thing. And the second problem is poor eating habit. Because if these type of caries are affected in the molar region, that means in the posterior region, there will be severe pain when they eat. What will happen is they will reduce eating. Always when they are taking food to school, they will just throw out the food and come back to home. When they parents ask, did you eat all? Oh, I ate everything. Like that. But they will be starving. That is the issue. Why they are saying and not saying to parents that I have toothache? Definitely the parents will take the child to dentist. Unfortunately, there is an issue. If a child is sick, if the child is taken to a pediatrician, there will be no problem. But if the child is taken to a dentist, there will be a severe problem with the child, because they have already heard that whenever we go to a dentist will take an injection, and using some steel instruments, the tooth will be pulled out and there will be severe pain, like that. Sometimes some parents are also saying like that to the child to frighten them. That is the issue. For some sake they are doing. Whenever we want to go to a dentist, these comments will create some problem. Injection, pulling out of tooth, pulling the tooth out, like that. So never say children that dentist is a very cruel person. That is what I have to say. So these people will not say anything about the tooth to the parents. They will suffer and suffer. During that time, they will not get sufficient nutrition for their growth. That is the issue. So whenever there is a problem with the tooth, it is to be treated. Then only they can eat and drink properly. Then only they will grow. That is the issue. And suppose there is a severe pain in the previous night of an examination, what will happen? They cannot appear, they cannot study, they cannot appear for the examination. So be very careful dealing with the children. Whenever you can do this, just open the mouth of the child and see whenever there is a black lesions or any problem in the oral cavity, better to consult a dentist. And we have to mention that a dentist is not at all a cruel person. is a very nice person, like that, then only they will come to the dentist. Otherwise, they will not come. They will hide all the problems. Once there is an abscess or a cellulitis, then only people will know that there was a problem with the this child's dentition or tooth. Already mentioned that a psychological problem will be there. They will be introverted, like that, and malnutrition will be there. Sleep problems also will be there. During night, there will be severe pain if there is an untreated caries exposed to tooth. That means the severely affected dental problem, the child cannot sleep, because during daytime they are in standing position, and the blood flow will be in the extremities, and when they sleep or lie down, the blood flow will be more into the head portion. The pulsating pain will be, so then they cannot sleep properly. That will affect the overall health of the child. So once in a while, just check up. Dental checkup is a must. And another thing I have to mention that is malalignment, that is malocclusion, that is improperly arranged tooth. That is another thing if there is a severe problem for the primary dentition. Treatment for this type of dental problem is, one is parent counseling. We have to mention about the feeding habit. I already mentioned there is a misconception also that if it is a deciduous tooth or primary tooth, why should we fill all these teeth and spending that much of money? All these teeth will shed. So many problems. That is why we have to give equal consideration for the deciduous tooth also. Okay, if it is unrestorable or untreatable or unfillable, abscess. If there is such an abscess, usually another misconception, that is giving antibiotics and analgesic. My opinion, or pedodontology,
interrupted sound.
drain the tooth. Vijaykumar?
Sir, can you hear now?
കേൾക്കുന്നില്ലേ?
ഇപ്പൊ കേൾക്കാം. ഇടയ്ക്കൊന്ന് കിട്ടാപ്പോയി.
അതെ, അത് ചിലപ്പോ നെറ്റിന്റെ എന്തെങ്കിലും പ്രോബ്ലം. ഇപ്പൊ ഓക്കെ ആണോ? ഇപ്പൊ കേൾക്കാമോ? ഇപ്പൊ കേൾക്കാം. Extra oral and intraoral abscess. The main thing I have to say that drain the abscess first, then give antibiotics and analgesic. Otherwise, that antibiotic cannot reach to that region because of the congestion of the blood vessels. So, drain first. There are two types of drainage. One is extraoral drainage, that if the abscess is that much and if there is a point, better to drain the abscess extraorally. And if there is an, usually there is a point in the intraoral region, drain from that region also. And third type of drainage is through the pulp chamber. That means using our instruments, we can open the pulp chamber and the pus will go out. Only when this pus is drained from the abscess, the antibiotics will be effective. That is the main thing I have to say. Treatment, if there is an abscess, treatment of the abscess is drainage combined with antibiotics. And if that tooth is restorable, we can treat it with the root canal treatment can be done. And if not possible to treat or root canal treatment is not feasible, better extract the tooth and give space maintenance. See this picture, that is a picture of a child with a Ludwig's angina. That is a severe infection of dental origin and affecting facial spaces, sublingual, submental and submandibular spaces are affected, and we can see that raised position of the tongue. That is the typical picture of Ludwig's angina. Treatment is, as you know, antibiotics. Before that, we have to drain the abscess through extraoral. That is, we can do in another method, that is semi-lunar incision in the just behind the chin region, and give antibiotics and analgesics. And Ludwig's angina also creates so many issues later. So better to not wait up to this stage. That is the main thing I have to mention. Another problem with this type of abscess, you can see it is an orthopantomograph, otherwise known as OPG. You can see a radiolucency in the left mandibular region. That is a cyst, periapical cyst. Because if the abscess or caries exposed to tooth or severely decayed tooth is not treated in any aspect, no antibiotic, no root canal treatment, no extraction, just keep the decayed tooth in the arch, it may later lead to a condition known as periapical cyst. You can see the bone of that region is totally resorbed and a cystic lining is there. Surgical removal of the cyst is the only method. So if it is too late, it may lead to this condition. Okay. Missing tooth in the oral cavity, I already mentioned. One is caries lead to extraction, untimely extraction of the tooth. Another is trauma, falling in the ground while playground or accidents. Some teeth may be lost. And sometimes congenitally missing tooth. That means the tooth burden will not be there in the arch. Then we can do many things like rehabilitation, like partial denture, or sometimes we have to give space maintenance. Here we can see so many caries tooth, root stems, not at all restorable, only root stems. Some root tooth can be restored, but some are very severely affected. In such situations, we are removing all the root stems. But problem is that if the deciduous tooth is removed untimely, untimely means, for example, a deciduous second molar shedding time is actually 11 years or up to 12 years. If that tooth is unfortunately extracted due to severe caries or unrestorable caries by the age of 6 years or 7 years, there are 5 years more to erupt the permanent tooth. During that time, what will happen is that extracted tooth area will be closed or shrinked, and that space will be almost lost. And by the age of 11 years, when the permanent tooth is trying to erupt into that space, there will be no space. So the use of space maintainer is to maintain that space either by removable space maintainer or fixed space maintenance. Here you can see that another slide, there is a space and fixed space maintainer is in place. In the left side, you can see partial denture. That's also give a good result for the confidence of the patient, because otherwise there will be no tooth, and even phonation will be affected. If it is given a space maintainer like this, patient will get a confidence also. I am again mentioning about the space maintenance. You can see that cartoon type of a slide. There is a permanent tooth inside the arch, and the deciduous tooth is extracted. There is much time for eruption of the permanent tooth into that space. Both teeth from both sides will come closer, and the space will be lost. That is the issue. So we are giving space maintainer for that region. All these use of space maintainers is depend on the age of the patient and the position of the permanent tooth which is erupting. If the permanent tooth is almost erupting, there is no need of space maintainer. That is mainly according to the age of the patient and the position of the erupting tooth. Then about the periodontal issues, we can see calculus and gingivitis in the inflamed gingiva in the lower anterior region. The main reason is poor oral hygiene, plaque, and calculus. It may lead to periodontal problems and bleeding from the gum. Even mobility of the tooth may occur. That here we can see stains in the teeth, upper and lower region. This is also stains are two types, intrinsic and extrinsic. Extrinsic means mainly from bacterial products and foodstuffs, drinks like that. Intrinsic means this fluorides or any drugs which is taken. Earlier, this tetracycline is a reason for intrinsic stains. Dr. Vijay Kumar.
Yes, Kannan. Hello.
ഒരുപാട് ലോങ് ആയി പോയോ?
ഇല്ല.
നിർത്തണോ?
വേണ്ട.
Okay. I am mentioning about the trauma. Tooth fracture. Here you can see a fractured tooth in the upper right, anterior region. Second one is avulsion. Avulsion means the tooth is come out of the socket. Mainly in schools, we can see during interval time they go for playground, and sometimes falling in the ground, some tooth may come out of the socket. Usually what happens, they will take the patient to the dental clinic or dental college, but the tooth will be in the ground itself. But our advice is that whenever there is an avulsion or the tooth which is come out of the socket, collect the tooth and bring the tooth to the dentist. If it is within half an hour, no doubt we can put that tooth into the socket itself after washing. That tooth will be live. Very occasionally it may become non-vital, or sometimes resorption will be there. Otherwise, if it is within half an hour, no problem, that tooth can be saved. We are taking classes to the school teachers and the parents. Many times we mentioned about the bringing of this tooth to the hospital, but many times we didn't find it out. Like that answer will be there. And the first slide, you can see a portion of the tooth is lost due to trauma. There is a material known as composite, that is a tooth colored material. We can add to that portion of the tooth which is fractured. We can add that material and we can cure it with some chemical reaction. We can cure it, and there will be a tooth-like material, and you can see the second slide. There is no difference. The same tooth-like material, that is known as composite. That can be done. Another thing, if it is that fracture is affected the pulp, we can do root canal treatment and we can give crown also. You can see the second slide, before and after. If the tooth is fractured very severely and blood is coming from the pulp of the tooth, we can do root canal treatment. Later, crown can be given. Okay. Tooth avulsion, I already mentioned the tooth is coming out of the socket. If it is, even after half an hour, we can manage. We can do root canal treatment and we can place in the same socket. And one thing I have to mention is that if you get the tooth from the ground after avulsion, if I am telling about the permanent tooth only, no? If the deciduous tooth is, this reimplantation is not that much successful, sometimes we are doing, but that is not that much of importance. But if it is a permanent tooth, better if the patient is conscious, you just wash the avulsed tooth and put in the oral cavity itself, because the temperature of the oral cavity. Second one is the saliva in the oral cavity will moisten the tooth. And if the patient is unconscious, never do that. And we can put in the same socket and we can immobilize the tooth with some materials. Okay. And if the patient is unconscious, we cannot put the tooth in the oral cavity because the patient may swallow it. So we can use so many things. One is milk we can use. This coconut water we can use. Milk, if you are not getting plain water, never let it dry. Never put the tooth, we find out, never put the tooth in the pocket of the child, or never wrap it in with a paper or cloth. It should be moist. That is why we can use coconut water or milk or anything. We can manage it, no problem. Another problem is hypoplasia. That is, you can see a picture with a yellowish color, and this is known as hypoplasia. That's development of the enamel is defective. There are so many reasons. Here it is amelogenesis imperfecta, dentinogenesis imperfecta, many conditions like this. I'm not going deep into it because it's a separate topic we have to discuss later. About malocclusion, mainly there are three types. One is class 1, second is class 2, and the third one is class 3. Usually a normal dentition, normal occlusion is class 1. That means normal mandibular position, maxillary position. Second is class 2. In class 2, upper portion will be placed forward and the lower portion will be little bit in backside position. And the third is just opposite. That is, upper portion will be inside and the lower portion, that is mandible, will be outside. You can see the condition of the teeth in class 1, class 2 and class 3. Usually, നമ്മൾ മലയാളത്തിൽ പറഞ്ഞാൽ പല്ല് നന്നായിട്ട് പൊങ്ങിയിരിക്കുകയും മുകളിലത്തെ പല്ല് നന്നായിട്ട് പൊങ്ങിയിരിക്കുകയും ലോവർ കുറച്ച് ഉള്ളിലേക്ക് നിൽക്കുകയും ചെയ്യുന്നതാണ് നമ്മൾ ക്ലാസ് 2. ക്ലാസ് 2 എന്ന് പറയുന്നത് മുമ്പിലത്തെ പൊസിഷൻ വെച്ചിട്ടല്ല, ശരിക്കും മോളാർ റിലേഷൻ വെച്ചിട്ടാണ് നമ്മൾ ക്ലാസ് 1, ക്ലാസ് 2 എന്നൊക്കെ പറയുന്നത്. പക്ഷെ ഒറ്റ നോട്ടത്തിൽ ആസ് എ പീഡിയാട്രീഷ്യൻ നമുക്ക് പെട്ടെന്ന് മനസ്സിലാക്കാവുന്നത് മുകളിലെ പല്ല് നന്നായിട്ട് പൊങ്ങി താഴത്തത് കുറച്ച് ഉള്ളിലേക്ക് നിൽക്കുന്നതാണ് ക്ലാസ് 2. ക്ലാസ് 3 എന്ന് പറയുന്നത് നേരെ മറിച്ചാണ്. അതായത് കീഴ്ത്താടി മുമ്പിലേക്ക് നിൽക്കുകയും മുകളിലത്തെ താടി ഉള്ളിലേക്ക് നിൽക്കുകയും ചെയ്യുന്ന ഒരു പൊസിഷനാണ്. അതും ഞാൻ പറഞ്ഞ പോലെ മോളാർ റിലേഷൻ വെച്ചിട്ടാണ് പറയുക. പക്ഷെ എപ്പോഴും മാൻഡിബിള് മുമ്പിലും മാക്സില പുറകിലുമായിട്ട് നിൽക്കുന്നതിനാണ് ക്ലാസ് 3 എന്ന് പറയുക. ഇതിന് ഡിവിഷൻസും സബ് ഡിവിഷൻസും ഒക്കെ ഉണ്ട്. അത് ഈ ചെറിയൊരു ടൈമിൽ നമുക്ക് പറഞ്ഞു തീർക്കാൻ പറ്റും. പിന്നെ ഓറൽ കാവിറ്റിയിൽ കാണുന്ന ഒരു കണ്ടീഷനാണ് മ്യൂക്കോസീൽ. You can see two pictures. The first one is mucocele and the second one is ranula. Usually in the lip region we can see mucocele. This is nothing but the blockage of salivary ducts due to trauma. Usually what happens is when the child is biting some region, there will be a blockage of salivary ducts and there will be a bulging. We can correct it by surgical excision of mucus. Mucus, that means saliva is filled in that. In the floor of the mouth, you can see same situation, but that will be appeared in a little bit bluish color because more vascularity in the lower floor of the mouth, and that vascularity we can see it as a bluish color. Usually we call it as ranula. The content and reason is same, blockage of salivary gland ducts. Then about the common oral habits in children. Main our concern is mouth breathing, tongue thrusting and thumb sucking. Mouth breathing, as you know, there will be a open mouth position. They are not at all using their nostrils for breathing. Mouth is using. The main reason for mouth breathing is one is anatomical. Anatomical reason is there will be some variation in the air passage. There will be some deviation, for example, DNS, deviated nasal septum, or narrowing of the air passage or something like anatomical variations. Then they will use mouth for breathing. Second one is obstructive. Some obstruction will be there in the air passage. For example, common cold or rhinitis, or some foreign bodies kept in the nostrils, something like that. Obstruction in the airway. Third one is habitual. Habitual means there will be no anatomical or obstructive reason for this. Only habitual, because they might have seen somebody is sleeping with open mouth position. They are using mouth only for breathing. So they will imitate. For example, if grandparents or somebody or neighbors or somebody is sleeping like that, they will just imitate them. There will be no issue. And correction of this habit is, if it is anatomical issue, correct it by surgical means. If obstructive, for common cold, we can treat this common cold or rhinitis with medicine, or remove the particles which they kept in the nostrils. Habitual also, we can motivate them. There are treatment for all these type of habits, motivation, then reminding them, and some appliance also used for controlling this habit. For example, mouth breathing, we can use an appliance known as oral screen. You can just see an oral screen which is fabricated after taking the impression of the oral cavity. We can keep this appliance in the oral cavity during night. They will use only nose. If suppose the patient is not that much adjusted to this condition, we can put some holes in the earlier stage to breathe through that. Then we can close that holes later. Then the normal oral screen can be used. Tongue thrusting, that is while swallowing, these children will push their tongue outside the mouth. You can see in the top slide, tongue of that child is kept in between the upper and lower incisors. That will create a problem, that is again anterior open bite. That open bite position is there. This can also be treated with some appliances. Habit reminders. So many appliances are there. If these appliances are kept in the oral cavity, removable appliance and fixed appliances are there. When the tongue is touched on that appliance, they will withdraw if the patient is willing. That is very important. If the patient is interested to stop this habit and to prevent these malocclusions, they will use this. Another one is thumb sucking. Reason for the thumb sucking, as a pediatrician, you also that much of aware about it. One is main issue is psychological issue, that negligence from the side of the parents or somebody, and some introversion. Or sometimes if they are kept alone at home, suppose if the parents are going for work and the child is only at home, during that time they will keep this for the security aspect. If they are keeping this thumb or digits in the oral cavity, they will feel that they are secure. And another thing, if they feel hungry, definitely they will use this. So many reasons. I am not explaining all these things. The issues is that again there will be an open mouth position. If it is an open mouth position, some other habits like tongue thrusting or mouth breathing will come into action. And there is a picture of a finger, that means thumbs. We can see some callus or some marks on the thumbs if a child is always using this. And if the child is using this method for a longer time, the malocclusion or resultant these defects will be more. Just to motivate them, there are so many appliances for preventing this like this. Since it is time is very late, I am not going to explain, but some appliances used in the palatal region are the methods to treat these patients. Thank you very much for your kind listening. It is too late. It's taken almost 2 hours, I think. Sorry for the delay, and thank you once again for your kind listening. Thank you very much.
Thank you, Dr. Kannan, for that crystal clear presentation. It is 100% practical. And I think in my 30 years of pediatric practice, I am hearing an extensive talk on dental problems in children for the first time, I should admit. And there are no questions in the chat box. That means that it is very clear to everybody. I think few questions can be permitted. Dr. Ajay?
Why not? I am ready. No issue. If anyone want to ask
anybody can. There is no questions in the chat box. We'll discuss.
Chat position.
Which is the paste you advise for children?
Chat box കാണുന്നില്ല.
Question.
Dr. V.K. Parvati Madam from Trichur.
Which is the best paste?
Parvati Madam.
Toothpaste. Which is the best toothpaste for children?
മാഡത്തിന് മലയാളം അറിയുന്ന ആളാണോ?
അതെ അതെ.
എന്നാ ഞാൻ കുറച്ച് ക്ലിയർ ആയിട്ട് ഒന്നുകൂടെ പറഞ്ഞു. പേസ്റ്റ് നമ്മൾ സാധാരണ പറയുന്നത്, നമ്മൾ ശരിക്കും ഒരു ടൂത്ത് എറപ്റ്റ് ചെയ്യുന്നതിന് മുമ്പ് തന്നെ നമ്മൾ ശരിക്കും ആ ഗം പാഡും ക്ലീൻ ചെയ്യുന്നത് തൊട്ട് കാണുന്നില്ല. ഗം പാഡ് ഉള്ളപ്പോ തന്നെ നമ്മൾ ക്ലീൻ ചെയ്ത് തുടങ്ങണം എന്നാണ് സാധാരണ പറയാ. ഗം പാഡ് ഉള്ളപ്പോ തന്നെ. മാഡം, അത് കഴിഞ്ഞിട്ട് നമ്മൾ ടൂത്ത് എറപ്റ്റ് ചെയ്ത് കഴിഞ്ഞു കഴിഞ്ഞാൽ നമുക്ക് ശരിക്കും ഗോസ് അല്ലെങ്കിൽ കോട്ടൺ, വെറ്റ് കോട്ടണോ അങ്ങനെ എന്തെങ്കിലും വെച്ചിട്ട് നമുക്ക് വൈപ്പ് ചെയ്യാവുന്നതേ ഉള്ളൂ ആ റീജിയൻ. എന്ന് വെച്ചാൽ കുട്ടിക്ക് ഈ ഓറൽ കാവിറ്റി എപ്പോഴും ക്ലീൻ ആയിട്ട് കീപ്പ് ചെയ്യേണ്ട ഒരു സ്ഥലമാണെന്നുള്ള ഒരു തോന്നൽ വരുത്തണം. ആ സമയത്ത് നമ്മൾ ഇത് ക്ലീൻ ചെയ്ത് തുടങ്ങും. പിന്നെ പേസ്റ്റിന്റെ കാര്യത്തിൽ എന്ന് പറഞ്ഞു കഴിഞ്ഞാൽ സാധാരണ നമ്മൾ കുട്ടി തുപ്പാനുള്ള പ്രായമായി കഴിഞ്ഞിട്ടേ ശരിക്കും പേസ്റ്റ് ഉപയോഗിക്കാൻ പാടുള്ളൂ. അല്ലെങ്കിൽ ഈ പേസ്റ്റ് എല്ലാം കുട്ടി വിഴുങ്ങിക്കളയും. നമുക്ക് പീഡിയാട്രിക് പേസ്റ്റ് ഒരുപാട് കമ്പനികൾ ഇറക്കുന്നുണ്ട്. അതിൽ ചീരിയോ ജെൽ എന്ന് പറഞ്ഞിട്ടുണ്ട്, പെഡി ഫ്ലോർ എന്ന് പറഞ്ഞിട്ടുണ്ട്, കിഡോഡന്റ് എന്ന് പറഞ്ഞിട്ട് പേസ്റ്റ് ഉണ്ട്. അതുപോലെ കോൾഗേറ്റ് തന്നെ അവരുടെ പിന്നെ കിഡ് പേസ്റ്റുകൾ ഇറക്കുന്നുണ്ട്, പീഡിയാട്രിക് യൂസിനുള്ളതാണ്. പക്ഷേ ഈ പീഡിയാട്രിക് യൂസിന് ഉപയോഗിക്കുന്നതാണെങ്കിൽ പോലും അത് പിന്നെ തുപ്പാനായി കഴിഞ്ഞിട്ടേ ഉപയോഗിക്കാവുള്ളൂ. സാധാരണ കുട്ടികൾ ഒരു 3 years ഒക്കെ ആകുമ്പോഴേ തുപ്പി തുടങ്ങുള്ളൂ. 3 വയസ്സൊക്കെ കഴിയുമ്പോഴേ തുപ്പുള്ളൂ. തുപ്പാൻ തുടങ്ങിക്കഴിഞ്ഞാൽ പേസ്റ്റ് ഉപയോഗിക്കാം. പീഡിയാട്രിക് പേസ്റ്റ് ഒരുപാടുണ്ട്. പിന്നെ ഇത് കൂടാതെ ഒരു അഡീഷണൽ ഇൻഫർമേഷൻ എനിക്ക് പറയാനുള്ളതെന്ന് വെച്ചാൽ, പേസ്റ്റ് ഉപയോഗിക്കാൻ അല്ലെങ്കിൽ തുപ്പാൻ തുടങ്ങുന്നതിന് മുമ്പ് തന്നെ കുട്ടിയുടെ പല്ലിൽ ചെറിയ ചെറിയ കേടുകൾ തുടങ്ങിയെന്ന് വിചാരിക്കാം. ഞാൻ നേരത്തെ പറഞ്ഞ കാര്യം മാഡം ശ്രദ്ധിച്ചിട്ടുണ്ടോന്നറിയില്ല. ഈ ഡീമിനറലൈസേഷനും റീമിനറലൈസേഷനും നടക്കുന്ന സമയത്ത് അതിൽ എഫക്റ്റീവ് ആവാതെ വന്നിട്ടുണ്ടെങ്കിൽ ചെറിയ വൈറ്റ് ആയിട്ടുള്ള ചെറിയ ലീഷൻസ് നമുക്ക് ടൂത്ത് സർഫസിൽ കാണാൻ തുടങ്ങും. ആ സമയത്ത് എന്താ ചെയ്യാന്ന് ചോദിച്ചാൽ, ചില റീമിനറലൈസിങ് എൻഹാൻസ് ചെയ്യുന്ന ചില കെമിക്കൽസ് ഉണ്ട്. മെയിൻലി കാൽഷ്യം ഫോസ്ഫേറ്റ്സ് ഒക്കെ അടങ്ങിയിട്ടുള്ള കുറെ ബ്രാൻഡുകളുണ്ട്. ടൂത്ത് മൂസ് എന്നൊക്കെ പറഞ്ഞിട്ട് ചില ബ്രാൻഡുകൾ. അത് ശരിക്കും കാൽഷ്യം ഫോസ്ഫേറ്റ്സ് അങ്ങനത്തെ ചില സാധനങ്ങളാണ്. അത് ശരിക്കും നമ്മൾ വിരലിലെടുത്തിട്ട് ആ കേടുള്ള സ്ഥലത്ത് നമ്മൾ ഓയിൻമെന്റ് തേക്കുന്നത് പോലെ തേച്ചു കൊടുക്കും. അങ്ങനെ തേച്ചു കൊടുത്താൽ അത് സപ്പോസ് അത് വിഴുങ്ങിപ്പോയാലും വലിയ കുഴപ്പമില്ല. പക്ഷേ നമ്മൾ ഈ ടൂത്ത് പേസ്റ്റ് വിഴുങ്ങാനുള്ള സാധ്യത ഉള്ളത് കൊണ്ട് തുപ്പി തുടങ്ങിയതിന് ശേഷം ഉപയോഗിച്ച് തുടങ്ങിയാൽ മതി. ഒരുപാട് ബ്രാൻഡുകൾ ഈ പീഡിയാട്രിക് യൂസിന് തന്നെ ഉള്ളത്. അതിൽ പണ്ടുണ്ടായിരുന്നതിൽ നിന്ന് വ്യത്യാസമായിട്ട് ഇപ്പൊ കൂടുതൽ ഈ സൈലിറ്റോൾ പോലെയുള്ള മീഡിയംസ് ആണ് കൂടുതൽ ഉപയോഗിക്കുന്നത്. കാരണം വെച്ചാൽ ഷുഗറി ആയിട്ടുള്ള സാധനങ്ങൾ ഉപയോഗിക്കുന്നത് കാരീസ് കൂടാനുള്ള സാധ്യത. ഇപ്പൊ തന്നെ നിങ്ങൾ പീഡിയാട്രിക് യൂസിനുള്ള പല സിറപ്പുകളും പണ്ട് വലിയൊരു ഇഷ്യൂ ആയിരുന്നു. സിറപ്പുകളെല്ലാം കൂടുതൽ സമയം സിറപ്പ് കഴിക്കുന്ന കുട്ടികൾക്കൊക്കെയും കാരീസ് ലീഷൻസ് കൂടുതലായിട്ട് കണ്ടിട്ടുണ്ട്. പക്ഷെ ഇപ്പം കൂടുതലും ആ ഒരു ട്രെൻഡ് മാറിയിട്ട് ബെറ്റർ ടാബ്ലറ്റ്സ് കൂടുതൽ കൊടുക്കുകയാണെങ്കിൽ കുഴപ്പമില്ല. സിറപ്പിൽ തന്നെ ഇപ്പൊ സൈലിറ്റോൾ പോലെയുള്ള ഷുഗർ സബ്സ്റ്റിറ്റ്യൂട്ട്സ് അങ്ങനത്തെ സാധനങ്ങൾ ഉപയോഗിക്കുകയാണെങ്കിൽ ഏറ്റവും യൂസ്ഫുൾ ആയിരിക്കും.
Thank you very much.
മതിയോ മാഡം?
It was an excellent talk.
താങ്ക് യു മാഡം. താങ്ക് യു.
Vijay Kumar sir.
Hello, Ajay.
Yes sir. Sir, if there are no further questions, I invite Dr. Ajit Subhash sir for his vote of thanks.
Ajit Subhash, can you mute?
Am I audible? Am I audible? Audible?
Unmute.
Yes sir.
Yes.
Respected State President of IAP, Dr. T.P. Jayaraman sir, respected Speaker Kannan sir, Vijay Kumar sir, State Secretary of IAP, Dr. Johnny Sebastian, State Chairperson Dr. Mukesh sir, Dr. Nandakumar, respected State ID Dr. CC, State IDA Secretary Dr. Deepo J. Matthew, President IDA Malabar Dr. Shaju Mandoli, Dr. Ajay, other dignitaries on the platform, my dear colleagues. As we know, implementing each and every step of President's Action Plan is considered as a great achievement for IAP. Betterment of oral health in children is a dream project of this year's President's Action Plan. A grand opening of this program has taken place here today. On behalf of IAP, I extend my sincere gratitude to Dr. Kannan sir, today's guest speaker, Professor HOD of Department of Pedodontics, Government Dental College, Kozhikode, for his excellent and informative talk about common dental problems in childhood. Thank you, sir. I also express my sincere gratitude to Dr. T.P. Jayaraman sir, State IAP President, for inaugurating this program and also for his presidential address. Thank you, sir. I extend my gratitude to Dr. Vijay Kumar sir, Professor HOD of Pediatrics, GMC, Manjeri, for moderating this program. I acknowledge my sincere gratitude to Dr. Mukesh sir, Chairperson of this program, Dr. Nandakumar MK, National Executive Board Member, Center IAP, to Dr. Johnny Sebastian, State Secretary of IAP, for felicitating this program. I extend my gratitude to Dr. Mohandas sir, President IAP Kozhikode, who, along with Dr. Ajay and Dr. Rahul, have taken a lot of pain in organizing this program in a fantastic way. Finally, special mention and special thanks is needed to the office bearers of Indian Dental Association, both state branch and Malabar branch, Without their support and blessings, we can't organize such a program here. On behalf of IAP, I extend my sincere gratitude to Dr. Joseph C.C., President IDA Kerala, and Dr. Jibu J. Matthew, Secretary IDA Kerala, Dr. Shaju Mandoli, President IDA Malabar Branch, for felicitating this program. Also, I acknowledge my gratitude to Dr. Unnikrishnan and Dr. Tom Jones, Office Bearers of IDA Malabar Branch, for helping us in organizing this program. We appreciate all-hearted support from IDA State Branch and from other local branches in future for organizing various programs in different parts of our state in connection with the enhancement of oral health in children. Finally, thanks to all the participants who have made this program a grand success. Hope it was a fruitful discussion for each and everyone. Thank you one and all. Thank you. Good night.
Thank you, sir. Ranjit?
Okay.
Thank you, sir. Thank you, Kannan sir, for the wonderful talk.
Thank you. Thank you very much.
Thank you, sir. It's a wonderful talk.
Thank
you, Kannan sir. So we can leave.
Okay. Sure. Thank you.
Good night.
എല്ലാരും ഫുഡ് കഴിക്കാതെ ഇത്ര നേരം വെയിറ്റ് ചെയ്ത് ഞാൻ ഒരുപാട് നീട്ടി. Sorry for that.
വളരെ ഇൻഫോർമേറ്റീവ് ആയിരുന്നു.
Informative talk.
Thank you.